else.
No worries. I appreciate it. Thank you for letting us have some time with you. I know that you've been really, really busy and traveling around the world and doing all kinds of things here lately and trying to treat patients at the same time. So thank you for taking some time to join us.
Sure.
Dr. Pino is the interim chief of the neuroradiology department at UT Southwestern, and
Okay.
Dr. Jill DeVee, hopefully she'll join here shortly, is one of the CNS radiation oncologists there. And Dr. Pino reached out to me about a month ago with with a lot of interest and questions about contrast clearance analysis. And of course, we wanted to go to somebody that's used this obviously successfully and regularly with patient treatments for some advice,
Sure.
and maybe even talk a little bit about how you use elements in the gamma knife world as well, because I think that that could also be something that's applicable to UT Southwestern.
So sure. Sounds good. So Marco, did you have specific questions I can answer while we're waiting for our add-on colleague from a
Yeah,
imaging point of view?
absolutely. And thank you again for your time. Um, uh, I will say that I think there may have been some miscommunication between admins. And I'm texting Dr. DeVee because I don't see her name on the meeting invite. So I think there have been some miscommunication between the admins. So I'm not sure she's going to join, but I'll definitely have the opportunity to ask some questions, and maybe I'll try to ask the questions that I think she would ask you.
Okay.
Hopefully that helps. So again, thank you for your time. We have used the algorithm for contrast clearance here at UT Southwestern to some degree. We have not had the Brainlab tool for it, but we have an imaging analysis lab here, and a couple of my colleagues wrote code to mimic what the tool would do. So we have generated our own homegrown contrast leakage, if you will, maps.
Sure.
And the reason we did it is
Yeah,
because
Bogdan is on the call, and he will close his ears.
mhm,
Actually, was able to reproduce it fairly fairly well with code myself. However, given that we operate in a licensed environment, we need an FDA-approved product on the table to use for patients. You can use anything you want in a single institution setting, but since we already have the tool, I was just playing with it to understand. So I'm not surprised you were able to write code to make that
yeah, we have
contrast.
played with it because we have one multi-center trial running here in which the principal investigator collaborates with some of the folks in Israel who initially
Yeah,
published, all the papers,
yeah,
and we wanted to see how our own maps would compare to them, just to see if that's something we could do. We haven't been using it clinically,
yeah.
more on, as you said, playing and seeing what we could accomplish, and we have seen some interesting results, somewhat promising, and that's why we're talking to Brainlab, because as you said, if you're going to move this from a clinical perspective, then we would try to obtain the FDA license, product, not only because it's, validated, but also because from a workflow perspective, it would be more seamless instead of, requiring a lot of
Yeah,
offline post-processing,
exactly.
etc.
That's been the biggest thing for us is that I have now my three mid-levels, and most of the residents are trained in using the software right here in radiation oncology, right here in Gamma Knife, and they apply it routinely, independently. Radiology for us does not process it. The software is actually in our department, but at the end of the process, we're able to export the map back to it's a DICOM format map. It goes back to PACS,
Yeah,
so it can be seen. But we're doing it ourselves, and you're right, it's extreme extremely easy to educate and train people to do so that I can have a little more depth in terms of how and who is running it. And we've also integrated it into our treatment planning. So, yeah, but
yeah,
that's just to give you a backdrop of what we do.
yeah. Thank you. So we're at this point trying to make the case for our health system and as well as our providers, mainly radiation oncologists, which I think is the main, service of interest here, about the advantages of potentially using this method. And the Brain Lab solution seems to be pretty robust, pretty easy to use. We already have Brainlab here as a provider.
Hmm.
So from a feasibility perspective, I see that as something that can be done. However, the obvious main skepticism comes from the feasibility of doing this from a scanning perspective, right? Our radiation oncologists are understandably so a little skeptical about how that would flow logistically, given the need for delayed imaging. And we have done that in a limited ability here on one of our hybrid scanners that
Hmm.
doesn't have as full as schedule. But
Yeah.
to deploy it more extensively, of course, the logistics of having to bring the patient back sometime
Yeah.
after and rescan.
Yeah.
That's one of that. I guess that's my main question to you.
How we get around it.
How to get around it, and
Okay,
are
so
you
I'll tell you what we
following
do.
the?
So you have had direct contact with the same people who developed this software. So Yves Mardor and Leon Zach and all those folks and from Israel. And if you ask them, and I'm deviating a little from the company script because the recommendation that has been made for 60 to whatever 90 minutes is based on perhaps the cleanest point where noise goes down and you get a very nice looking map. However, if you ask them, they'll tell you they see the difference already at about 17 to 20 minutes. So what I have done without actually validating it, and that's just even though you're the guys in Texas, we're the ones who are playing cowboy here. So quite honestly, we have done it a little differently. What we have agreed upon is our 3D, our contrast administration occurs upfront, and we obtain all sequences after contrast. So we do the 3D brain MPR or MPRage or brain volume acquisition right off the bat, and then run everything else post. And once that is done, by the time you finish with all the sequences of a brain follow-up scan, this is for follow-up. And just so you know, we defer it on the day of actual treatment. So if I'm using TRAM as a follow-up tool, which I do, then that's how that'll be run. It'll be ordered as an MRI brain with contrast clearance. It's a special request within the EHR, and it triggers the tech to pull up that protocol, which will then front load the contrast administration in 3D 5 minutes later, and then follow it with all the other sequences. By that time, you're looking at about 30, 35 minutes. And we just run the tram study at that point. So one table time, an additional
Got it.
7 minutes at the end. But we're running everything else post. Now, that does put your flare post contrast,
Yeah.
which can cause in a undiagnosed person that could be concerning, but in patients with known metastatic disease, some would actually argue. The group from Toronto Western actually will tell you that they like to even post flare post contrast T2 flare because
Hmm.
it shows better the leptomeningeal disease. So you may have
Definitely.
to, yeah. So you could certainly play with that idea for your metastatic population. I think you could implement contrast clearance in that way, and that would not make table time an issue. So especially since this is not a reimbursed portion of the exam. So a
Yeah.
second table slot with no reimbursement is very hard to convince anybody. Now we do provide our MRI here because we're a cancer center and our brain MRI volume is nearly 2,000 plus scans a year done by, just for me. So I have some leverage, but I don't abuse that leverage. I certainly don't make him put it on. However, if I am planning to treat someone based on a contrast clearance study where the contrast map will be used to target recurrent residual disease, then in that setting, I will allow a full hour and I will put the patient back on the table. And that's just
Okay.
because now I'm starting to act more quantitatively than qualitatively on my study. So to call necrosis versus residual tumor versus recurrence, I think it's okay with that 25-minute, 30-minute time frame. And you get pretty good results. Every so often you get a noisy contrast clearance map that gets much quieter when you wait longer. But
Mm.
the noise is you're not looking at the whole brain. You're looking at specific targeted areas. You always have your T1 study to go with. So you're really focusing on what you're looking at, and it's fine for that. And that's how we've done it for the longest time because we faced the same initial barrier. I just felt that the value of this information was so much for us that to not have it was losing out for the patient.
Got it.
And so I sort of explored it and looked pretty good. We were comfortable with it, and we've done that. And that's been our way of getting around it.
So as a summary, your average time post injection is around 35 minutes,
35
right?
minutes, 35,
And
sometimes a little more. Just depends on how the patients do with the scan. The
Yeah,
longer they're on the table for whatever reason, the better it is for us.
I see. And the exception is for the cases that you actually are convinced enough to retreat. And in
Right.
those cases, you will
Then I give
have
them
a.
a 60-minute, and they what they'll do is it's a gamma slot in the morning, so they'll scan my tram patient first, and then
Mhm,
they'll put another patient on, finish that, and then put the tram patient back on and scan them. So now I've got a good 60-minute window there. Sometimes they'll scan
yeah.
two people and then put them on, just in case they're moving really quick. Because typically our gamma knife slot is just a flare and a 3D brain with
Mhm,
contrast. So it's a shorter slot, but they work it out. I mean, they know they
yeah.
have to do it. And I can also, just so you know, there are times the MRI will come down, we'll look at it, we'll say we've seen the new lesions, but look at this one that we treated. I really should have gotten a contrast clearance on it. We'll just call upstairs and they'll take the patient back up and quickly run the single sequence for me. So we have some play and flexibility, but I try to give a nod to the standardized technique more so for therapeutic intervention, but for follow-up, I'm quite comfortable with that shorter timeline. I should probably run a trial on this and write it up because I
Yeah,
bet you
yeah.
that's a very
That that's
important question.
that's a barrier that most institutions are facing. So you would
Yeah, I
it
know
would
that would make a lot of sense.
it would make a big difference in the
Bogdan, you're
field.
listening to me, right? Figure out some way to get me some money to do this, man.
Yeah.
He's laughing because my institution
Uh,
doesn't let him give any money.
no.
It's not him.
Yeah,
Trust
yeah,
me.
yeah.
I work for the state of New York. By the
Yeah.
time we finish the bureaucratic paperwork to get that kind of support, we will have changed a few administrations. That's the tragedy. But I think I'll do it. I think I'm gonna make a way to figure it out. I'm gonna just repeat the contrast cleared study at the end of sequence, have the patient wait, and do another one another 30 minutes later, and compare the quality of those
Hmm.
two tram scans. That's pretty straightforward. But I think I
Yeah.
should do that because this is the number one question. You're right.
Yep.
Yeah.
Yeah. That's the number one question in everyone's mind.
Yeah.
So, as far as your protocol, you mentioned the T2 flare being post contrast. I'm assuming you're also not running any T1s pre contrast.
Not in these patients because it really makes. Sometimes they will run a T1 if they have any concerns. They'll quickly do that, then inject, then do the T1 post, and then do everything else. That's a case in which case my tram gets kind of pushed in just a touch. But generally speaking, they were quite comfortable with just proceeding straight off.
Yeah, the main concern for me would be, interpreting hemorrhage. If, these patients usually have prior studies, but if there's any bleed, in between, it might be tricky to see that
You can throw an
hemorrhage.
SWI in there. You'll be able to pick it up that way. The SWI will not be contaminated by contrast injection.
Yeah, yeah, it's not
It's not perfect,
the
but it's
yeah, yeah.
because especially it's very fresh blood susceptibility won't be as. But I think you'll be able to do it. I mean, generally speaking, like I said, our follow-ups are many, many, many. We treat about 850 patients a year, so we have roughly nearly 20 follow-ups a day. So those patients are being strictly followed on the basis of their disease control and progression. And sometimes when they have symptoms, they've had a CT done, we picked up on a hemorrhage, then they'll go through a more traditional scan protocol where they get the pre and the post and everything. But that's been my workaround for so far.
And are you using this contrast clearance protocol on all your gamma knife treated patients? What is the patient population you're using on this?
So this is basically the way this will trigger is you will do a standard follow-up, which is an
Hmm.
MRI with contrast,
Hmm.
and say I see an area that's looking abnormal. Then
Got
I
it.
look at the amount of abnormality. If it is enough and there is some edema and there's clinical concern, then what I will do is sometimes instead of wasting scan time, I will book them for so here's how it'll happen is let me bring one more variable in there. You have a follow-up scan, you're 6 months out from a treated area. There
Hmm.
is a treated area that's looking abnormal, and you also have a new tumor. Now, that's a person who's coming back for treatment, so their treatment planning scan will include a tram. So that way I know I'm bringing them for gamma anyway. I'm going to treat the new target. I'll use the same visit. Now, for instance, someone has no new spots, but has two areas that are looking like they may be
Hmm.
radiation effect. That's a person who will then break cycle and for insurance approval purposes probably come back 4 weeks later unless they're super symptomatic and get their tram study. So I
Got it.
don't do it right away, but about 4 weeks with brain mets, you can usually get the insurance to agree to pay for another MRI. And
Makes
so I
sense.
time it out that. So I mean, I kind of time it clinically. Now, if they're super symptomatic, we're just going to do it. You know, And that's a rare circumstance. Generally, you have time. And so that's how we parse that aspect of it. GBMs are just a little bit different, and sometimes in GBMs we'll electively just do contrast clearance on the day of planning anyway, because that's validated. We validated the metastatic material that's published, so we know that blue is tumor, both in METs and in GBM. And actually, we now have very good data for atypical meningiomas with good correlation of TRAM-positive blue areas with gallium-68 dotted 8 positive areas
Mhm.
and perfusion-avid areas. And so it's actually, and we're now looking at our vestibular schwannomas, and we're showing that the central non-enhancement post-radiosurgery is all red and the core viable tumor is blue. So actually, this technique picks up viable tumor quite well. Of course, I'm sure there are tumors that either hold contrast longer or flush too quickly, and maybe this technique may fool us, but in general, it seems to correlate very well with what we're doing. The most important thing that we have probably picked up on is that if we are several months out from treatment, just like in the body, if we are seeing persistent disease, we often retreat it. And we've shown, not published, but shown that, and I've talked about it, the hazard of not doing that is almost a 2.2 factor, the hazard ratio.
Mhm.
So if you treat early and in response to a TRAM-positive area, that's solid tumor, retreat early, I mean, hiding your dose within that blue area, then you end up with better overall control and PFS. So there is that little aspect too, that it could inform your decision making. I don't know what your trial was looking at, but that's the other aspect of it. Are we waiting too long for radiological response? Are we missing persistent disease? And just like elsewhere in the body, where oligometastatic is now being pursued and where retreatment is often considered for persistent disease, often after biopsy, the same idea for the brain here. We just don't want a biopsy, so we use the contrast clearance instead.
Yeah, well, anecdotally, we've and it's good that you mentioned this. By the way, sorry, I was just texting Dr. Deville. Devi texted me back, and she's joining. Um,
Perfect. Perfect.
so I think it's good timing actually. Dr. Devi, can you hear us?
Yes, my apologies for not joining
And no
earlier. I think
problem.
it
No
was a
problem.
miscommunication.
No problem. I
No
think it was
problem.
miscommunication in the background. So thank you for joining again. Uh, Dr. Prasad has been sharing a lot of details about his practice. I think it's really useful information. The session is being recorded.
Okay, perfect.
But it's good to have you as well because we're getting to the meat of the topic. So
Okay.
far I have focused on some of the technical aspects and logistical aspects, which are a source of skepticism. And Dr. Prasad was sharing with us how he has gotten around some of the logistical challenges, some interesting approaches to it. So I can brief you in more detail about what he does, but in a very short summary, he is doing he is doing this as a troubleshooting, for the most part, technique in patients that are being followed, in which he suspects there's something abnormal that could be either progression or radiation changes, right?
Okay.
And he's having to make a decision. So he has created a structure in Epic to trigger a special MRI
Okay.
based on contrast clearance, and that will be triggered by the treatment team, your team, and who else uses it for metastases and gliomas, and he's now starting to explore that in anaplastic meningiomas and other tumors. But basically, when that happens, instead of using the initially proposed approach by the Israel group of scanning the patient and then bringing the patient 60 minutes later, based on talks he has had with that group, they claim they can actually start seeing a signal as early as 17 to 20 minutes. So what he is doing is he is basically doing pretty much everything. He's starting with the contrast injection
Right.
in those cases, and then he's acquiring pretty much everything post contrast. So at the end of the day, the delay between the first T1 pulse and the late sequence ends up being on average 35 minutes, which
Okay.
allows him not to have to take the patient out of the room and bring the patient back, right? Now we've been talking about his intentions of writing this up as a trial because that will be make a huge impact because most people that have spoke about this technique are skeptical about this idea of bringing the patient back and that would solve that problem. But he's still figuring out a way to do that. So there are
So
exceptions to
just
this workflow.
Jill, this has worked very well for us. Just so you know,
Right.
we as I was mentioning before to you on the call that we have definitely more noise sometimes because
Hmm.
if you wait longer, you get a cleaner background. But if
Right.
you already know the area of interest and
Right.
focus, then it makes very little difference. It allows
Okay.
us,
I
and it
see.
allows me to get the data on a larger group of patients. We have typically 20, maybe 25 follow-up MRIs every day for gamma knife
Right.
practice. And out of that, a couple might get a contrast clearance, maybe three every day. So
Right.
we are doing these at a very significantly high rate, and we repeat them if I'm actually therapeutically intending to use it for treatment again. Then on the day of treatment, very likely we would do a more standard delay of 60 minutes just to have that resolution, because at that
Okay.
point I'm really trying to nitpick how much is actively blue, and
Right.
that's what we want to retreat, because retreatment volume is
Okay.
a
Right.
consideration. We want to cut it
Right.
down. So,
Right.
and somebody had asked me, I think Henry had mentioned in the beginning, how we integrate all this. So, I mean, literally our Brainlab station's sitting right next to my
Right.
gamma plant station. And the
Right.
data moves seamlessly through here. We're
Right.
also, from a radiation oncology perspective, all our anatomy segmentation for my GBMs and spinous BRT is all done here. So from
Right.
my point of view, spinous BRT anatomy is a 15 to 20-minute job,
Okay.
and GBMs likewise. So the process is often we see the consult, we know we have the post-op MRI, and that'll already be segmented and waiting before SIM occurs.
Right.
CT for spine, we do use the SIM CT, and we're also using it in our AVM workflow now.
Right.
Not given up on the frame-based technique for treatment yet, but we're certainly using it to explore. What it lets me do is use earlier DSAs into this process. So that's just a broader Brainlab and elements application. So it lets me use non-stereotactic angio, and also follow-up angios can be aligned. So there's a lot of
Right.
value to it. There's in the big suite. But from a radiology
Right.
perspective, the big thing has always been how to time the contrast clearance,
Hmm.
and
Right.
and that's how we kind of got around it.
Right. And I guess, Marco, how do you think that would work? Because would that be something we can do on clinical scans? I think you mentioned before we would probably need to do it within the setting of a trial. Because I imagine your normal scan slots are probably 25 minutes for an MRI brain. And so this would
Um,
extend
So,
that
so my,
normal.
my suggestion would be just try it on a handful of patients for
Hmm.
yourself.
Okay.
And I'm going to start working with my team to see if I can actually do a 25 and then a delay, and accumulate the data and write it up. And if you end up doing the same, we can work on it together. But the point is that anybody with a large volume practice for radiosurgery definitely has a need for these scans on a regular basis. And I have had practically, clinically, no problem. And a lot of our validation work where we compared the blue areas with viable tumor on operative pathology were based on those earlier scans. So
Right.
it's not, but again, that was not the focus of that paper. So we were not really talking about our deviation from the prescribed technique. And as I said, all that it helps is takes the noise floor down. But if you're willing to accept focal review. And the reason I know it works is because if I see new brain mets, they're solidly blue, even at that
Right.
30-minute time
Right.
point. They're
Yeah.
solidly blue. My treated areas have the blue and red. Everything has a small red rim because there's always a little leaky area
Hmm.
around it. But it really
Right.
is, and we haven't used it, although I've thought about whether this could guide us into a tighter treatment field. Not everything that's contrast enhancing is probably tumor, but to get to that level of resolution, that may be our internal CTV that's built into our radiosurgery practice forever and ever. But contrast is obviously leaking around into irritated
Right.
brain just around
Right.
tumor. So there's all these aspects to it, but that's how we got around because we just felt this was so much more valuable information. For years and years, we managed radiation damage best just by Gestalt and imaging and best guess, as Konsolka would put it. But I don't think that's the way. This is much more objective. And what it lets me do is my team can handle this for me. My three med levels can run the analysis, all the residents can. So they're already approaching me with an early opinion of what they think is going on.
Hmm.
And that just
Right.
focuses my attention to patients who really need it. rather than going through every scan and wondering what the heck is this.
Right.
And we did show that. We have not published it yet, but we definitely see that if you react to that persistent blue, say 6 months out from treatment, and
Right.
retreat it, the hazard ratio separating the two PFS curves is almost 2.2.
Yeah.
So there's benefit to retreating like we do in the body. If we see
Right.
persistent disease, this is like a surrogate biopsy of active disease.
Right.
So from a logistical perspective, Joe, I think that if we create a special MRI order protocol for this, which we can trigger on as per needed basis, like doing by Dr.
Right.
Prasad, we have slots that go up to 45 minutes, so
Okay.
we could fit that into those slots. Assuming it's not very high volume, which it shouldn't be, because we're only talking about cases that come up either in multidisciplinary conference or in your
Right.
clinic that you already have a suspicion, then I think we can make it work. Now, for the confirmatory scan he's talking about, that he does the full 60 minutes, the
Right.
way he's doing this is he's typically doing this in the day of his gamma knife planning study. So he does a gamma knife early on, and then he brings the patient back 60 minutes later. So I think this may be possible. We have to figure out because your gamma knife scans are being done on the COH inpatient scanner, right?
Right.
And they're early in the
Right.
morning, so that would help.
Right.
So there may,
It
because that,
does, and it, just to clarify, it does sometimes mean choice of patients has to be adjusted a little because some days, I mean, I can't have three METS patients that require contrast clearance on the same day. That's just going to,
Right.
despite all the flexibility I typically have 7 slots every day. So it will not go well with my team upstairs, even though they love me, but I don't overdo it. So typically on a given day, there'll be a single tram. Now, as I mentioned earlier, there's definitely going to be situations, and I was telling Marco that we're down here planning and we look and say, hey, this looks, I need to know more about this one lesion. And I'll call up radiology and they'll say, yeah, send the patient back up. So they'll do the contrast clearance scan for me on the same. Now, the trick is it has to be back on the same scanner. And we have 3 scanners. So that does raise, sometimes they have a breast or a biopsy going on or something. And I'll be like, oh my God, it's going to take another 45 minutes. And that's when I end up in the, even sometimes a little beyond the 90-minute standpoint. But I'm okay with it because if it's truly damaged brain, the contrast hangs for a very long time.
Right.
So those are just clinical things. Like we have a day, we suddenly feel like, and I've had that happen to as many as sometimes 2 patients in a given day, where I've sent them back up for a clearance scan. So
Right.
that's really a matter of how your slots are set up. We have command on the scanners early morning, starting 7 a.m. At least 2 scanners, one for framed and one for frameless, and that's been there for a long time. And we're a very busy practice. I think we sustain the economics of the MRI radiology department quite a bit as well. So we have a little
Yeah.
bit of that leverage going for us. Um, when I started here, we had 1 scanner. We have 3 now. So, and for a cancer center, that's quite a few in our size footprint. So that's how we play with it. I mean, the good news is that what I can say is that I know Marco mentioned your homegrown software. The advantage of a preconceived FDA-approved click and shoot package is that you can train a greater depth of people. I don't always have the time, but I have many, many people I can trust to run this. Radiology doesn't run it because there's no Brainlab station in radiology. They would if we really went to that point. We still run it down here and we push it right back to PACS. So the final map is in PACS, but it's processed. And actually, as a result, I end up processing all the follow-up contrast clearance for the entire neuro department, not just the ones I'm gamma knifing, but even the ones neuro-oncology is following up. So there's always this scan ordered by them and then a text to me, hey, can you run the analysis? And well, somebody will, and we'll push it back. But just so you
Right.
just so you understand, we've integrated it in a very sort of flexible way. It's been 5+ years now. It's almost second nature. In fact, radiology approached us and said, hey, listen, we're just creating a new template for you. You keep ordering these things and it screws our timeline. Why don't we just create a request study that's got a specific name to it so we can build the time for it? And that's what they did. So, like you mentioned, Marco, if there are 45-minute slots, then those contrast clearance studies would automatically end up in those slots. and that will solve your problem. And I think the map is valid for a fair amount of time. So if you have to retreat based on it on elements you can draw, so you can draw out the blue areas and export them as a structure. That's our standard approach. We see a mixture of red and blue. We want to retreat the blue. We'll mark it out in contrast clearance on SmartBrush, export it back to Gamma Plan as a structure, and plan and treat to that. So it's all seamless. And once we get the auto segmenter, which we've already tested and published on, then finding the mets automatically will be easy. And uh, that will mean most of our time will be just spent in delivery because we do treat, on a really busy day, we may treat about 40 or 50 brain mets over 6 patients. So it's at 7 minutes a pop. That's still a lot of time.
Right.
Dr. DeBee, I don't know that we've had a chance to talk about that together, but he's mentioning a new release of auto tumor detection and auto segmentation for brain
Yep.
metastases. And then there's also an anatomical segmentation tool.
Oh, I
as
see. So
well
they
within
don't
the whole
have. So
package.
we definitely have all of those. So I'm using the auto segmenter, that is doing all the auto contouring for us, and that's standard part of our external beam practice. It's also a standard part of analysis for gamma knife. What's nice is if you want to look back at your studies and you want to look at hippocampal or brainstem doses that you never segmented and we never do for gamma. So you can just go back and run those scans through it and pretty quickly have it populated and then get the DVHs exported out. So we've done that for several papers. We've gone back and retroactively segmented. We use, of course, fiber tracking for our functional cases, and I use fiber tracking for field design in my GBMs as well now. So parcellation has become part of it. But the auto segmenter, which is auto tumor detection, which is not yet out, but hopefully soon, by fall, I'm told it'll be out. Just we've already published in the journal Neuro-Oncology our own experience with it. It's very high correlation with our own finding, a few false positive, few false negatives. But the good news is if you have 20 brain mets, it takes at least a minute per met. So you're drawing for 20 minutes. This finishes it in 45 seconds.
Right.
And you just have to review and make sure they're right. And there's also a very nice retreatment follow-up tool. So you can follow sequential images, select the target in question, see a volume trend, see a response trend. There's all sorts of things that come with it. That still needs a little bit more work to automatically track each lesion that's been treated, but I'm sure that'll ultimately happen. But for us, it's a very integrated. I mean, it's literally like the clearing hub. We have rad formation too. We had MIMS in the past, just so you know. I don't allow rad formation on my patients because it's all CT based and we're doing everything MR based. And the spine CT segmentation of Brainlab is far superior to anything else, especially because it creates the RTOG targets automatically. So once you draw on your target of interest, the CTV volume is auto-generated. So lots of that is not what Marco is looking at, more like what you look at, but we're using it as an essential part. I don't have the delivery platform, unfortunately, ExactTrack. Otherwise, I would optimize my SBRT within Brainlab as well.
So, Jill, so I think that, the approach being used here can be potentially replicated where we are. We have to figure out a couple of pieces,
Right.
again, a protocol we're going to be comfortable with if it's going to be mostly post contrast. But again, those studies are not being done as the routine surveillance protocol. They are triggered by a concern. So I think it all comes down to us partnering to try to coordinate this in a way that's reasonable. Another interesting comment that I asked him was about the timing, and he said that since he's triggering his contrast clearance scan, the 35-minute one from another surveillance scan, he typically waits 4 weeks to order that to get insurance approval, right? Because the patient, let's say the patient just had a routine follow-up, and then he doesn't do it immediately, right?
Yeah, and it only happens immediately, Marco, is when there is another new MET, which I have to bring the patient back for treatment anyway.
Right.
So then on the treatment day, I will add in the contrast clearance. So that's in a way a escape hatch. But in cases in whom there is no new disease and we are only concerned about progression versus reactive response in a area, If they're not clinically symptomatic, you do
Right.
have the opportunity to wait 4 to 6 weeks and re-image it, but that time do it along with the other, because you know what's going to trigger, if no retreatment, it'll trigger potentially the use of Avastin for us. So all those questions come
Right.
up. You know, how
Right.
big is the area? Does it need surgical clean out? That happens 3 or 4 times a year, but we need that decided. So the moment I order that scan, it'll be collectively reviewed in neuro-oncology, us to see, do we go back and remove more of this, or should we start Avastin? And all that's happening as a result of that second scan. But I have the
Right.
time to book that out. I'd typically say 4 weeks, because normally we do 8 weeks, and if it's negative, then I'm at 12 weeks for everybody. Anytime they have a positive scan, they drop back to 8 weeks follow up. So I am going half that time in a question of adverse effect, primarily because I may have to do something to counter the adverse effect. If it's radiological, not clinical, I have the full 4 weeks. If it's clinical, then I speed it up, and that's okay too. I mean, yeah, there are ways to get around the whole insurance issue. If I call it a planning scan, they don't care too much, and
Right.
we
Yeah.
just were able to manage that.
Yeah, so I think, I know this is being recorded, and obviously I missed more than half of it. So I'll, take my time later today to kind of go back and listen to the entire conversation.
Sounds good. And also ask Bogdan to share with you. He has probably the video on their site of the presentation I just gave in Geneva,
Okay.
looking at
Right.
longitudinal follow-up, using this as a tool.
It's already up, so
Okay, perfect.
Henry
If
can
you,
follow up with that link for you if you want
yeah,
to listen to it.
that'd be
That would be
great.
great.
So
I'll send a
between this,
follow-up email with all of
yeah,
that.
great. Between the recording and this, between the recording, this conversation and that talk, I think most of your questions will be answered.
Right. Right. And
And then you
otherwise,
can,
I'll
yeah, just
send an email.
call or
Yeah.
email. Yeah,
Yeah.
it's easy.
That sounds
Easy.
good. Yeah, my apologies again. I think,
No
somehow
problem.
it wasn't
Anytime.
well communicated with me. Yeah.
Henry and Bogdan both have my cell phone number. They can share it with you. I'm happy to take a call anytime.
Yeah.
No problem.
Thank you.
Sure.
So
Anything else?
that's
Marco, any questions?
no, I think that was super productive. Dr. Devi, I think, once you have time to re-listen,
Right.
maybe we can get a follow-up meeting to discuss. I
Yeah.
think it will take a little bit of a village to get it going, but
Right.
I'm willing on the side of radiology to try to support it and do what we can to create the infrastructure to run it smoothly. And I will, maybe you could be the point person in radiation oncology to, talk to your colleagues and see,
Right.
their level of interest. I would suggest we start this with radiation oncology, and maybe if it's successful, we can bring in our neuro-oncology colleagues as well,
Right.
because I'm sure at some point they'll have interest.
Yeah.
But I think
I
that
think you
radiation
should include,
oncology,
I think I would include neurosurgery in this too, because trust me, it's transformative. The decision making is often a combination of more treatment from a radiation standpoint, altering course in neuro-oncology, certainly for GBMs, and reresection, all of which is, the original intent of the Israel group was GBMs. We've extended it to brain mets because that's our a
Right.
much bigger practice for us. And
Right.
and also retreat GBMs, Jill, we're typically targeting positive areas or contrast clearance positive areas
Right.
only.
Yeah.
So
And
that
that's
allows
nice.
you to really narrow down the area.
Right.
Sometimes a residual, say we see a residual post-op, will establish with contrast clearance that is residual. I'll
Right.
finish my 6 weeks. I'll immediately turn into a boost and do a boost right away.
Right.
And I can tell you it works now for atypical meningiomas as well, post-op.
Right. Yeah.
Actually correlates very well with gallium-68. So there's a
Okay.
lot of value here from a clinical, practical point of view. I think it really transforms the way you think
Right.
in radiation oncology. But I think it has impacts, Marco, for neuro-onc as well as neurosurgery. But you could do it stepwise manner, and it'll get you. It'll transform the way you think. That's why we integrated it with you know we're
Yeah.
we're a little less skeptical and a little bit more in charge of our work environment. I have a little bit more say in radiology, so maybe that's helped us leverage this sooner. But honestly, at this point in time, if I didn't have it, it would be, we had it down for a day one day, and it was a tough day because we literally had people waiting to be decisions to be made on. Maybe we've atrophied our other thinking cells because of this, but but we don't guess as much anymore. I think, and it correlates very well with CBF studies and blood volume studies and PET scan. It's not It's not a myth.
Right.
Yeah.
I think that's exciting. I mean, there's definitely, hearing this, there's probably a lot of avenues in which we can use it. But yeah, obviously we have to be careful how we roll it out. I do think, Marco, on the longer term, neuro-oncology, they follow our GBM patients for a longer time than us. So, I do think having them being able to order the scan and then bring the scan to tumor board to discuss with all of us would be helpful.
Yeah, all team members will ultimately be part of this. My point is just start small with radiation oncology leading.
Agree.
Because we don't want to, overstretch ourselves. And then once we get comfortable with the workflow, we can start expanding. So
and keep in mind early on, understand who's going to process them and put them into packs, because it's not a lot of work, but it is work. And so we are currently handling it ourselves, but just be aware of that. Give me 1 second. Hello, Laszlo, give me 1 minute. All right. If that's all, then I'm going to sign off, and contact me with any further questions. Okay.
Thank you so much. I appreciate it.
You're welcome.
Take care.
Bye, guys. Thank you very much. I'll send out the recording. Have a great day.
Yeah, thank you. Bye.
Take care.